Here goes. Right, I hope everyone's enjoying their lockdown and finding safe things to do with their children. And I thought I would talk about sort of something slightly gastro-related, but also very general, and which is failure to thrive. And it's obviously the terminology around that is quite varied, and people are trying to find the right terminology to talk about it. Failure to thrive may be a bit outdated, so we'll talk a bit about that. What are we going to call it? And just hide that. And I'm going to go through a case which is quite complicated, which will take a lot of the talk, just looking at what actually happened in a tertiary setting with a child with this sort of presentation, and then alongside that, just think about how we can be effective when we're looking after children with the problem. Not you know, a bit of a targeted approach, not to do endless investigations, try and keep things moving because it can be difficult. The story starts with a toddler, 18 months old, a bit more than 18 months, 1.5, and was in a dietitian clinic, was already known to the hematologist as had been diagnosed with sickle cell anemia on neonatal screening, Nigerian family. And this child was in the dietitian clinic because she had fussy eating and poor weight gain. As you can see there, her weight was on a significantly lower centile. At this point, Richard, can I just check that you can hear me and it's all okay?
Yeah, all good.
Okay, good. I'll carry on. So there are the numbers, the anthropometry, quite a big discrepancy between the weight and height centiles. And the dietitian had stated that the weight and height are 2 centiles apart, and therefore she is faltering growth. So she met that particular practitioner's requirement for being given this this descriptive label, and as well as actually dropped 1 centile over the last 5 months. And I think by that she meant a weight centile. And there was some communication. Communication wasn't easy because the mother didn't speak very good English, needed a Nigerian interpreter. And the dietitian found that this child was eating 3 meals a day, but the portions were very small and quite unvarying, and it was quite a sort of stereotyped diet with Weetabix and milk and rice and various things, not much protein. She was a bit worried about that. The child was drinking some milk from a beaker, was eating these kind of snacks, and having generally healthy-ish childhood diet, but just a bit lacking in variety and volume. And she was beginning to feed herself. She wasn't sort of terrified of food. And I've just reminded me what a wonderful food Wotsits are in the right setting. But dietitian advice was, as you might well expect, to just add fat food wherever possible, to sort of introduce it into the child's diet, to offer plenty of desserts and treats and fatty treats, and then the child came back some time later, wasn't eating much more, so was then offered a supplement drink, one of these high volume, high calorie per mil supplements, which some children like. I've mentioned the hemoglobinopathy. At the moment, that wasn't causing any problems, but she was meant to take penicillin prophylaxis. She continued to see the dietitians quite regularly because not much was changing. She was remaining very thin, and more information was emerging socially. That family was having quite a difficult time. Neither parent working, father with some quite bizarre health problems, not really functioning as a father or in any sort of job, and there wasn't much money for food. And the family would often ask people they met if they could access more funding. The child was due to start nursery. That was thought to be something that might be helpful, because she would at least get 1 meal and be in a situation with other children eating. Now, just to break out of the story there and think a bit more about terminology, what I guess everyone has to make his or her own mind up. There isn't a generally accepted term that we use. Now, failure to thrive is still out there. If you put it into Google, you'll get lots of information. It's still used in publications. It's still used in databases. So that's still an accepted term. It has that slightly pejorative word failure in it, which is for many parents is going to make some aspects of the problem harder. So it tends to steer away from that in the clinical setting when you're dealing with parents. Faltering growth has been proposed as an acceptable alternative. Again, faltering, I'm not sure if I like that word, but it's also used. Faltering growth, faltering weight gain. You can be very, very blunt and just say this child is not gaining weight appropriately, i.e. not following the WHO growth centiles for a child of his or her geographical location, ethnic background, and so on, or just not gaining weight as expected, which can be even more to the point if it may be that the medical fraternity feels the child is not actually too underweight, but there could be some family expectations that the child should be bigger. So not gaining weight as expected is quite a good term for I find, for day-to-day clinical use when you first meet the child, and you want to keep things open, but you want to give a problem, to use a problem list. Another way you could do it, you could say that if you decide that the child is not getting the calories he or she needs, then undernutrition could be a relevant label. And malnutrition is not quite as specific because obviously we also have a problem, particularly in this country, developed countries, of overnutrition. So malnutrition could apply to overnutrition or undernutrition. So if you're being very precise, undernutrition would be better. And one phrase which is a bit wordy, a bit of a mouthful, but also sort of quite specific, so I quite like it, is poor weight gain in children in resource-rich countries, because obviously children who aren't gaining weight where there just are very scarce resources, then it's likely to be just lack of access to food. So that's another term up there, insufficient weight gain. That's another good blanket term. As I said, consensus lacking, and then it does beg the question, if weight gain is insufficient for what? Is the child so undernourished that there is deceleration of linear growth? The child who was zooming along the 50th centile for height until their second birthday, and then something goes wrong and they start dropping off the height. The weight drops off first, then the height follows, or the head growth is affected. So it could be so insufficient that there's stunting happening. Could it be that there is a cognitive or gross motor consequence of the lack of nutrition? Could be that the child's very tired or lethargic and can't cope with a full day at school. So there's a number of consequences of undernutrition beyond just the weight that you see. Also, I think it's important to consider the age range we're dealing about, because failure to thrive is a term which is used even for adults and older people. So and in pediatrics, the sort of pathological landscape changes a bit as the child ages, and I found it helpful for this talk. I found I was mainly thinking about children up to 2 or 3 years old, because after that, if a child's been doing well up to that point and then things start changing, the weight starts dropping, I think the sort of considerations change a little bit. And lastly, there is a universal cause for this, and despite lots of confusion and frustration, but the universal cause is that there is not enough utilizable substrate. So once you've established that this child is not gaining weight in a healthy fashion, then the final common pathway is not enough nutrition going into the blood and going into the various metabolic pathways. So not enough utilizable substrate. So another mouthful, but it is good to remember that there is a final common pathway, because there's lots of confusion about is it malabsorption or maldigestion or whatever. So I tried a few definitions. Some of these are from the literature. Here's one, I think it's from the States: weight below the second centile for gestation corrected age on more than one occasion, and then some allowance there for syndromes which will make you small. I couldn't actually find a definition of the interval between those measurements, whether it's 1 week, 2 weeks, or 3 months, but there needs to be some sort of interval so that it's not just a one-off deceleration. Here's another definition, using a combination of metrics, again that sense that you need to have a time interval, because you're talking about velocity of weight gain, so you want to see the weight gain slowing down over a period of time in proportion to the height, which is staying on its weight centile. And then again, they're using the weight less than the second centile. This is my own personal definition, which I thought I'd share with you, and it was that a child with insufficient weight gain is the child in your clinic whose parent or grandmother or health visitor, or in my case, referring pediatrician, thinks it's too small to be healthy. Just a little note there, because we're very dependent on growth chart. Rightly so, we utilize growth charts as a very useful tool in pediatrics, and just to remind ourselves where they come from. Are they just, where do we get this precious data, these precious data? And there's actually this wonderful project that was done, what are we now, over 20 years ago, hard to believe, by the WHO, the Multi-Center Growth Reference Study, with some wonderful data from all these thousands of children in a nice diverse set of countries, just to really get normative data for various populations. So it's well worth a look at how that study was designed for anyone who's interested in global health. Back to the toddler, our story. So if you recall, there's this girl with sickle cell that wasn't making her sick, but whose weight was very slim, who was very fussy with her eating and had a slightly difficult family in terms of social setup. And she stayed under the hematologists and the dietitians, and her BMI was not good and it wasn't getting better, and she continued to have advice about high calorie foods with supplements. And it came to the stage when the dietitians felt that more than half her calorie requirements were being met by the Fortini, the milk drinks, and that none of the other strategies were really helping. By 2.5, the mother was pregnant with her 4th child, and there was a 4-year-old older sister who may or may not have come from Nigeria, another sister possibly in Nigeria waiting to come over. A little bit later on, she's 3, she's starting nursery. The nursery teachers are concerned about her. She doesn't eat very much, she doesn't drink very much, and they have a team around the child meeting, so social work's involved in the community. The BMI is stubbornly on the 1st to 3rd centile. She has regular contact with hematology, and the general dietitians are working together to try and help, and she seems to develop some respiratory problems, some snoring at night, some nocturnal desaturations maybe, so a bit of obstructive sleep apnea possibly. And she's maybe not as drinking as many of the supplements as she's being offered, or not being given them, and the dietitians feel it may be coming to the point where she should, for her own health, physical health, mental health, maybe less so, but physical health certainly, to have some nasogastric top-ups, which is unusual for a 3-year-old. I think you'll appreciate a supposedly cognitively normal 3-year-old to have a nasogastric tube put in. Now, yes, so the teachers agree. They've also noticed that her abdomen's quite swollen. The dietitians are building up this case for nasogastric feeds, and the hematologists then get on board with that plan. Do some basic investigations at that stage, quite some hematological ones as well, clotting, but nothing came back. That's her tummy. That was reported as having a very big stomach, which I hope you can all appreciate, full of gas. But then the rest of the bowel, there is gas in the rest of the bowel and some poo around, as you always see with children. Not quite sure why the tummy's so big. They wonder, had she been crying, had she swallowed some air? Now this spoiler alert here, because as you know, I'm talking about her when she was 3, and she stayed with us, so you can kind of see what happened afterwards. But there she was when she was 3, really, with her, this is her weight, hanging around the lower centiles there with a bit, when that's where she had the nasogastric feeding started, around 3.5. Her height very nicely on the sort of mid 50th, sort of plumb on the 50th centile there. So height not really affected by all this, height soldiering on. BMI now somewhat dependent on the weight, on the height rather. Height's variable, as we know, measuring height in children, so that probably accounts for the BMI being a bit all over the place, but the trend is, you can see the trends there. She was admitted for nasogastric feeds. She started laxatives because it was first she was constipated, and they wanted endocrine and gastroenterology assessments, and her father was going to stay and look after her on the ward because he has seizures or pseudo seizures, which means that he's not safe to look after young children on his own. He sort of will have a seizure when he's holding a hot cup of tea and it will spray all over the kitchen, and various reasons. He demonstrated this on the day of admission. She was seen by the gastroenterology registrar soon after the admission. She looked malnourished. The abdomen was grossly distended. Some of the medications were noted and the plan. Some tests were considered. They may or may not have been done, but that was what the gastroenterology reg wanted from her point of view. So celiac screen, kind of obvious, hopefully. Thyroid test, not a bad thought, although the height is fine. Cognitive is fine, and some common food allergies, fair enough. Nasogastric feeds go well, so there doesn't seem to be a problem when the food goes in. It does stay down. There's a little bit of vomiting, but once the milk's in the stomach, seems to stay there and go on through. Now, there's concerns about the father's behaviour and ability to care for his daughter grow during the admission, driven by his erratic behaviour. The child is noted to be able to eat cake, so when she likes the food, she eats it. She pretty much just likes cake. She can drink water easily without difficulty, without choking or gagging. And again, the rest is around father's behaviour and safeguarding team. It wasn't an easy admission for any of the frontline staff. Any thoughts at this point? I'll just get the chats. I'll have a look at the messages that are coming through now. And if anyone wants to ask or make a suggestion now, why is it dropping out? Dropped out of the slideshow. But anyway, it was just a space to ask any questions at this page. So someone's thinking neglect emotional possibly is sort of the main etiological factor, which is a good suggestion. Someone's thinking about stool studies, looking for parasites, maybe worms. Yeah, worms as a cause. We could talk about that later, but worms as a cause of weight loss in this country, less common. But yes, there's that Nigerian background, but there hadn't been any travel. And now obviously the safeguarding, people are picking up on the safeguarding, lack of emotional support, which is a very good point. You know, is this child a child that's just had some early difficulty with establishing feeding and has been a bit neglected? So yes, I like all those thoughts, and we've also covered some of the basic investigations. Did anyone think of refeeding risk? We'll never know. The ward did, so we were quite careful not to feed her too much too soon and to do some blood tests to look for changes in phosphate and potassium, those signs of refeeding syndrome. She had the investigations we talked about. Would anyone want to do any other investigations? We've had an abdo X-ray, we've done celiac. Someone said stool studies, so yes, we'll think about those. Anything else? Any more imaging? Trichobezoar, yeah, that big stomach. We might have seen that on X-ray if it'd been a hair bezoar in the stomach. I think it would probably have shown up on X-ray, but not a bad thought. Ultrasound, good. Metabolic screen, like all of those. My thoughts were also, you know, what is the contribution of this very unfavourable psychosocial or apparently unfavourable psychosocial media? And it's all very well, we've got her here on nasogastric feeds and she's doing okay, but what are we going to do when the time comes to go home? Yeah. And as you'll see, that was a dilemma for some time to come. This is just dropping out of the story, and these are the sort of questions I ask myself in a maybe a more typical clinic patient. I ask myself, is this just a genetically small child whose nutritional needs are in fact being met? So that's again a bit wordy, but I'm just trying to get all the information into one sentence. Where it's my impression that actually this child is, you know, is getting enough to eat, doesn't want to eat anymore because is meeting his or her appetites, growing according to her own sort of schedule, healthy schedule. So is the child in proportion, height and weight, BMI okay? Was one or other of the parents small? That's when you can do a mid-parental height. Might the child have a syndrome which is programmed her to be small, such as Turner syndrome? And another question I would ask is this a constitutionally slim child whose weight is increasing appropriately, albeit along a lower centile than our height? And again, quite wordy, but I mean, I've definitely met in gastroenterology, you meet children who are just not interested in food, and it's quite fascinating because most people have the opposite problem. But they do just seem to be very uninterested. It's not a sort of classic feed refusal or what do we call it, oral aversion. They nibble away a bit, they're very busy, they've got lots of energy, and they just burn it off, and they're thin, and they carry on like that. So that's a group of children too, which can cause alarm to parents and even to some of our colleagues, dietitians. I asked myself, is there a mismatch between how much food, there you go, whoops, I don't know why it keeps doing that. How much food is being delivered to this child's gut and his rate of growth? So this is getting at the question of, is there actually the child unable to utilize the calories? Calories are being provided, but there's some problem with getting them where they need to go. So taking them up from the gut or being wasted once they've been taken up by the gut. So if the answer is yes, this child, I'm really sure this child is eating lots and lots, and I really don't know why that food is not contributing to growth, then I start to ask, is this a gut problem, primary gut problem? Is this malabsorption or food not even getting into the digestive part of the gut because it's being vomited out of the stomach? So, you know, food going to stomach, not going any further, or food going into the small intestine and then not going where it's meant to go. So diarrhea, vomiting, that's my stock in trade. Could there just be, or again, enough food going in, but child not growing? Is the energy going somewhere else? Is this, some children that you have them in the clinic room for 15, 20 minutes, they do not sit down. They don't stop. This may be ADHD, that's not my area, but you know, it's not, most children will spend some time sitting down, but some children will not stop. And I'm sure there's a group of children, again, who just burn off and just literally almost can't quite keep up by how much they eat. They're just destined to be slim and active. This is a complicated slide from Up to Date. It's a very good database. Some of you might have access to it. It's just to show you that while in some cases there will be a clever diagnosis, congenital syndrome or metabolic syndrome, if you actually look at the list of problems here, particularly from 6 months onwards, they really are much more psychosocial behavioral, really. And so I think that tells the story of this condition, that there really is, it's often going to be the solution is going to lie in that area, that arena. Now, having asked myself those questions, I need to answer them and give the family some explanation about why I think what I think. So I'm going to take a very thorough history, and I'm going to do a thorough examination. I'm going to try and keep an open mind about what I might find. But at the end of all that, if there isn't an obvious cause of the small intake, I'll probably do some basic investigations. You can't really come to a gastroenterology clinic and not have a celiac screen, so you're going to have one of those. You're probably going to have your thyroid checked at a full blood count at least, because that will tell me if there's some strange anemia thing happening or just really bad nutrition. And then on from that, I mean, if there isn't any diarrhea at all, is there any point in looking for fat malabsorption, either from cystic fibrosis or something rarer like Swatchman diamond? But a stool elastase will be quite a good substitute for that, because it will show you pancreatic insufficiency. So not a bad test to do if you're a bit stuck. And CF, I suppose, can have a range of presentations in younger children of the right ethnic group, so a sweat test is something that will be done fairly early on. The other investigations, I think, will be directed by the history. So if there really isn't any vomiting, I probably wouldn't go looking for too much upper GI pathology, but if there is, then I'd certainly want to make sure there isn't something congenital, because we see a lot of malrotation that seems to improve when they get the lab procedure. Now, that's going on to management. We're doing quite well for time. We've got another 10 minutes before 3 o'clock. Does anyone want any questions at this point? I'll just tell people, can you all see the messages? Are they all shared? Richard?
Yes, they are.
Okay, so that's good. So we can see so there's these good. People think of Hirschsprung's disease. Yep, so there's been some constipation. That's a good thought. Hirschsprung's without the sort of obvious sort of enterocolitis picture, the sort of neonatal enterocolitis that usually makes us think about it, but yeah, so sort of more occult form of Hirschsprung's. I mean, really, if it's a complicated case that's not improving with the basic things, then I think the key thing is a multidisciplinary team. And I know that phrase gets used a lot, but if you think about the case we've been talking about, it was really, really helpful to have all the other health professionals, out in the community, the health visitors, the community pediatrician, the social workers, even the people at the nursery who were sharing information and gathering information, and the dietitians at King's who were able to do these detailed calorie assessments could really help us in that process of deciding if it's an intake problem or a malabsorption problem. So multidisciplinary team really is very important, and safeguarding at King's as well. Reassuring parents, so that's high on the list as well, because the parents are going to feel frustrated because there probably isn't going to be a black and white diagnosis. It's going to be very easy for them to feel that they've failed in a very sort of fundamental duty of a parent to provide nutrition and growth, and so that's going to be hard for them, and hard for them not to feel some way at fault. Might well want to involve psychology, GP, so even more of a multidisciplinary team. And I think it's fair to say it's likely to be a long process. These should not necessarily children that should be seen and discharged because they don't have a sort of complex underlying pathology. I think we should make ourselves available to support our community colleagues if we can. Now, going back to our child, she was admitted, if you recall, she's about 3.5, and she's really very thin, and they're feeling that her health has been compromised by her lack of intake, so they want to put her for a nasogastric tube. And she's admitted, and all these other things happen when she's an inpatient. She has a neurology review because her father shares that she's seen her having unresponsive episodes. She has a common assessment framework referral to community. She has an allergy review, and they wonder if she should try a cow milk-free diet based on not much, an IgE of 1.21, which is low, but anyway, give it a try. It's fairly simple. An endocrine review, who feels she doesn't have a genetic syndrome, and she has preserved linear growth, and this is very likely to be intake related. Also the comments that IGF-1 can be a bit misleading in undernutrition, can be low in undernutrition because of nutrition rather than because of growth intrinsic deficiency. She has a CGH array just in case she has Turner's. She has an upper GI contrast because there was a little bit of vomiting, and I think the surgeons were asked at one point to have a look, and sure enough that showed something, as if you do enough investigations you will see something, as I'm sure you all know. In this case it was a filling defect in the proximal duodenum, and remember she had that big stomach on x-ray, possibly that's why the upper GI contrast was done. I wasn't actually involved at that stage, so it might well have been because of the big stomach. And so there was maybe some reason why she can't process food out of her stomach, and could that be putting her off eating even though she's not actually vomiting? So she did have an upper GI endoscopy under the surgeons rather than the gastroenterologists, and the scope passed through the upper gut without any resistance or obvious anatomical abnormality. So it wasn't a duodenal web, but they did wonder if there was some extrinsic compression to explain the barium findings, although endoscopically they felt the caliber of the gut looked normal. So there's still some question, maybe a little bit of gastric outlet obstruction from something. So she had an MR of the abdomen, again with some non-specific findings, which might or might not help explain why she doesn't enjoy eating. This dilated esophagus, dilated proximal duodenum, dilated large bowel loops. I did feel she was constipated based on MRI. Whoops, back. Do we go back? Now, just to go back to my point of these cases not being easy, particularly when there are social difficulties, that initial stay for NG feeds ended up being for 3 months, just because they couldn't really find a way out once they'd admitted her to the ward and found that the family probably didn't have the resources to do nasogastric feeding at home, apart from the fact that nasogastric feeding at home on a cognitively normal child doesn't seem quite right. So that was a difficult decision. So she did languish on the ward for a long time. Well, maybe not languish. I think she was quite enjoying all the play therapy and the attention. She gained weight well, but the majority of her kilocalories were going through the tube, and ultimately she went home with the tube. The milk-free diet didn't make any difference, so she was back on normal formula. She had these radiological gut findings which couldn't quite put them all together to add that to the plan, really, anything to deal with. And the father's behaviour was obviously continuing to cause alarm, although the mother did appear to be caring and capable. Any questions at this stage? I think just people who might think about maybe Hirschsprung's enterocolitis, I mean, it is a good thought. There was no sort of, there wasn't a history of delayed meconium. The radiological changes were in the upper gut. So there wasn't really a suggestion of obstruction in the lower gut. So, but she didn't have a rectal biopsy. Vomiting, we get asking questions about vomiting and questions about was she being fed orally. All through the admission, she was being offered oral food. She was never told she couldn't eat. She was always encouraged to eat oral food, ordinary food, but the day would go by and she wouldn't have it, so she would end up having most of her calories. The vomiting was always on the minor side during the admission. There was a little bit of vomiting around the time of tube insertion, but it wasn't a big feature of her to vomit a lot. And she was able to have bolus gravity feeds. Didn't have to trickle the milk in. So she went home with this tube and actually ended up being at home with the tube for quite a long time because there wasn't another other way out. And I got to know her when she was 5. She came to my clinic with this tube in situ, and the referral was actually from the community. So as I said, bolus feeds. The community paediatrician said, we've got this child with a nasogastric tube. It's time for her to have a gastrostomy because all her feeds are going by the tube. she also had this constipation and soiling. She had the child in need plan, and mother, when I saw her, the mother was saying that she did vomit a lot. So I wanted to revisit the idea that she had dysfunctional upper gut, and I certainly wasn't in a rush to put in a gastrostomy without some more explanation about why it was needed. So here we had this nasogastric dependent child who's now 6, going to school, having the tube at school. So I did a repeat variant study, which came back normal this time. So whatever was showing up before seems to be temporary or an artifact. I saw her sequentially a few months later, and the vomiting had also improved. Mother wasn't said she stopped vomiting. So then the best thing seemed to be to get all the people that were looking after her together and just discuss our own different points of view and what the best way forward for her. That would be hematology, my team, gastroenterology, general peds, safeguarding, community pediatricians, dietitians, social workers, and teachers. We were able to have this meeting. The consensus was at this point because it was either sort of say this child who really isn't going to do well without a tube, so put in a gastrostomy, at least that's going to free up her face and get her socially feeling a bit more integrated, or actually is this a chance now to just see whether she can manage without a tube. They had been trying to reduce the amount of milk feeds, tube feeds, and she'd been losing weight, so she did seem to still need it. Nevertheless, I thought I was keen to take the tube out and see what would happen. Obviously, she would need careful monitoring because she was at risk of getting quite undernourished quite quickly. So we agreed that she'd come to King's weekly for clinical review and blood tests as appropriate. Without the NG tube, her weight was pretty static, didn't really put any on. She didn't lose it that quickly either. After a couple of weeks, she came in for blood tests, and she was very lethargic. We were worried about dehydration. We thought blood tests would be a good idea. I was very interested in the U's and E's. I thought maybe her urea would be up. So I had a quick look at those on the day she had them, and they were fine. Probably didn't really notice that her hemoglobin was 28. And luckily, she went to the hematology clinic the same day, and they were more interested in the hemoglobin than the U's and E's. And they noticed it was 28, and that was because she'd been started on hydroxyurea, and the parents got confused about the dose with the liquid and had been giving her a huge dose of hydroxyurea and given her this pancytopenia. So no wonder she was lethargic. So she was admitted again at the start of another long admission for more support, mostly around the hematology education and more safeguarding. Since then, she has managed to not have a tube, and she hasn't got a gastrostomy, and obviously with a lot of social support, but her weight is still pretty static. And we can have some questions now. This is a suggestion for entertainment for later if your lockdown's getting a bit boring. Maybe has anyone been looking after had trouble with a case of failure type? People find it a challenging consultation? I'm getting some questions here. Gastric dysmotility and lead poisoning, that's another good one. Did she have a biopsy with the endoscopy? So gastric dysmotility, she hasn't had any sort of motility studies as such, which could be anteroduodenal manometry. When she had or even an impedance study, because vomiting wasn't a key feature, we demonstrated that she could cope well with stomach feeds, with bolus stomach feeds. So it was felt that although her stomach does have a tendency to be distended and her stomach fills with gas, that she does move food through. It's not really a motility problem clinically. Lead, I can't really comment. It's been a while since I did general pediatrics. I think neurologically she was fine. There wasn't really any concern about lead poisoning. Biopsy with OGD, the surgeons did it, and I think true to their nature, they didn't do a biopsy. They had a quick look and didn't do biopsies because they don't if they don't see anything. Another suggestion would be a lactose-free diet. Well, yes, I guess for the gaseous distension of the stomach, maybe she'd be more comfortable. She hasn't, I think most of the formulas she's on, most of those enteral formulas are lactose free. So she's essentially on a lactose free diet. People are thinking about her future because that is, I go back to the growth chart actually, because that's contemporary. Where's that? See where she's at. There we are. That's her weight now. So yes, she's still, after that, you can see where the tube came out. The weight's drifting down again, so she's back in that territory of second centile weight. I think, yeah, it may not be the end of the story, but obviously, if she can track along this centile, even if she can track along this centile, not go down further, and her height's maintained, and she seems to have enough energy for school, then hopefully, we're actually doing her a favor not putting a tube in, because she will learn to eat on her own. And as you're inferring, yes, if she, it's quite powerful to demonstrate that a child puts on weight in a hospital setting, albeit with a nasogastric tube, because it does show that the gut function is there. We didn't have to give nasojejunal feeds or anything complicated. They were just bolus stomach feeds. Yes, you had people ask about the other children, Araf, and there was one note that said the other children were slim, but they didn't have the same problem. Their heights and weights were much more in proportion, and they were actually, I think, quite as they grew a bit older, they were very helpful with this patient, trying to encourage her to eat. They were on the helpful side. Question. Did she say why she didn't eat? So that's a very good question. She's quite quiet in clinic. Have I ever asked her? I think she does eat. She just eats a small amount. So maybe from her point of view, she does, and she likes drinking. I've seen her drink water and juice with enjoyment. So maybe she doesn't quite know what all the fuss is about. Yes, psychology. So the psychology of her, yeah, would be very interesting, even at her young age. That's a good point, just to start to explore that now she's a bit older. So I think that's a good. I think I'll take you up on that. Family stress. I think that's probably the key thing. My feeling would be, you see, while she was on the ward, I've spent this morning looking at the nursing notes, and there was concern right through that her father would really ignore her if she was crying in the night on the ward, if she wanted some help going to the loo or getting a drink, and he just seemed to be able to completely blank her out. So I think probably there's some real attachment problems. So speech and language, she may well have had speech and language, but it was very clear, even to the non-specialists who assessed her, that if you saw her drink, there was really no problem with swallowing. There was no choking, gagging. She was very comfortable swallowing. It was a real reluctance to eat. She would put food in her mouth, just hold it in her mouth, and then it would sort of fall out again in nursery. Whereas drinking, if she was thirsty, she would absolutely drink. The first slide. So yes, she did. She's been seen to enjoy eating small amounts of cake, but not full meals. So my first couple of slides. In terms of how she's performing at school, I don't think there are major concerns that she's particularly behind or that she should have an ed psych assessment. Actually, she engaged well. She enjoyed being on the ward, play therapy. She's quite engaging. In terms of liquid diet, when she's offered the right amount of milk, drink, supplements orally, she doesn't tend to take enough to gain weight. So it's still a combination of liquid and solid food. It's not a particular problem with solids. She doesn't have autistic traits that I'm aware of. She's up to speed with communication. So people are asking, what's the best clinic to refer a child like this to? And as I said, she actually she did end up in gastroenterology outpatients at the request of the community pediatrician, but only after she'd had a nasogastric tube for quite a long time. And she was seen as a ward consultation by the gastroenterologist, but because there wasn't thought to be a primary gastroenterological problem, gastroenterology didn't stay involved. It was community pediatrics and social work and so on. And then it was only when the question about appropriateness of gastrostomy came up, gastroenterology got involved again, rightly so. All right, I think that's probably the end, is it?
Yeah, any other questions or anything?
Someone's just asking, do I feel that opportunities were missed in retrospect, and that's easy? And what is the diagnosis? As I said, failure at the beginning, failure to thrive, weight gain less than expected. These are descriptive terms, and often there won't be a single diagnosis. And I think that's the point, is to keep in mind that they're going to be multifactorial problems with a sort of multidisciplinary solution. And I think in this child, you know, when the calories are there, supplied to the stomach, she grows. And then there are these sort of difficult social setting where she developed this tendency to refuse food. And what was the other question? That was the diagnosis. In retrospect, were any opportunities missed? Really hard to say. I think you know, she was slim, possibly with slightly earlier intervention, multidisciplinary team intervention in the first year or two of life. Maybe she would have found a way to enjoy eating more. It's very hard to say. It wasn't as if she had an underlying diagnosis that was missed. The abdominal swelling it's not a big concern now, no. And she's off the tube. She's off the tube, weight static. I think the idea of a bit more of a psychological assessment now would be very interesting. Actually, if anyone's still listening, I think 80 of you still are. There was a term that was used by community pediatricians about children, younger children who it's a more modern term than oral aversion. Some of you more general pediatricians might know what it is. I can't remember off the top of my head. There's a sort of psychological profile that can be done. Okay, I'm going to sign out now. All right, Richard?
Thank you very much. That's been great.
All right.
And everyone's still here. Remember to fill in the feedback forms. And next teaching session, I think, is tomorrow morning.
Okay, bye.
Bye-bye. Thank you.